In psychiatry, diagnoses are syndromes. Even in cases in which we understand the etiology of a given condition, we know that the illness is hereditary, and so it's largely genetic. Even in those cases, when you diagnose a condition in psychiatry, you are diagnosing a syndrome, which is a constellation of symptoms. And so two individuals may both meet diagnostic criteria for major depressive disorder, say, and share zero symptoms in common. You could have one patient who is having a lot of anxiety, a lot of insomnia, lots of tearfulness, irritability, and agitation, who has major depressive disorder. And then you might have another patient who also has major depressive disorder, who's lethargic and hypersomnolent and anhedonic and is experiencing cognitive symptoms and psychomotor slowing. And those two patients who both have major depressive disorder need two completely different types of antidepressants. And similarly, schizophrenia is not one illness. It is a variety of ailments that some are genetic and some are probably the result of in utero insults. We simply don't know what the etiology is. But one individual with schizophrenia compared to another individual with schizophrenia not only may have different symptoms that are prominent. One may hallucinate, the other may not. One may have paranoid delusions, the other may not. One may also have superimposed major mood episodes. Depression is very common in schizophrenia, but there are many possible symptoms, positive and negative, and two patients that have that diagnosis don't necessarily have the same condition. They don't necessarily have the same etiology or pathophysiology. There are distinct ailments that all could lead to a clinical diagnosis of schizophrenia, which again is a syndrome. At the end of the day, it's not like diabetes, type 1 diabetes, where you could say it's the failure of the beta cells in the aisles of Langerhans that aren't producing insulin that cause this problem. That's very specific. All type 1 diabetics have that problem. They're not making insulin. It's a failure of specific cells in the pancreas. And so it's not a syndrome, type 1 diabetes. It is a very specific illness, and everybody who has it has the same pathophysiology. Treatment's going to vary depending on the severity, but all of those individuals require insulin. Type 2 diabetes is caused by insulin resistance, and so we see it in morbidly obese individuals, and certain races are at greater risk, but it's always related to developing insulin resistance, and so insulin isn't always necessary, and weight loss and diet can make it much, much better and can even put a person into remission. So even in those individuals, you have to tailor the medications, which ones you're going to use, what the doses are going to be, depending on how severe their condition is and how well they're able to improve their diet and their lifestyle. So treatment is always going to be tailored, but everybody who has it has the same pathophysiology. And so the approach is going to be the same. It's going to be the same medications. It just depends on how many and how much we need based on the severity. But in psychiatry, it's very different. You can have two individuals that have the same syndrome, but they have widely disparate symptoms and therefore need very different psychotropic medications that always should be selected with their mechanism of action in mind. So what are we trying to do? Are we trying to block dopamine? Are we trying to increase serotonin? Are we trying to reduce adrenaline, or are we trying to increase GABA? It's about neurotransmitters, neurotransmitter systems, the balance between those. And then when an individual develops side effects, we need to understand what the proper antidote is based on pharmacodynamics, not diagnostic labels, because those labels can be correct, but you can't treat a diagnosis in psychiatry because the nosology simply gives us a framework, a paradigm to understand what the likely course of the illness is going to be, what the prognosis is, whether the symptoms, say for example, psychosis, are primary or are secondary to some other disturbance, such as a disturbance in mood. And certainly a substance-induced psychotic disorder would be treated in the short term very similarly to schizophrenia, but in the long term, those patients would be taken off of antipsychotics, assuming they can achieve and maintain sobriety. But if we label them with schizophrenia and we treat that, and 20 years later, they haven't followed the course of that illness, there's no progression, there's no deterioration, no negative symptoms, no cognitive symptoms, but they've been on Risperdal for 20 years because they went to the hospital one time after smoking methamphetamine and they were paranoid and hallucinating. They've taken this medication for decades unnecessarily, and it can certainly lead to a lot of physical problems, many of which are permanent because we treated a label.